Good evening, all the faculties and delegates for the Searchlight 19 Core Connect live webinar. I am welcoming all the faculties and webinars, which is initiated by Cancer Prevention and Relief Society. Dr. Asha Jain is a medical director of this society, and in the association with Jodhpur, Jorhat, Junagadh, Kadapa, Kalyani, Katiyar, and Bhimavaram Obs and Gynae Society. So first of all, it's my privilege to welcome our convener, Dr. Sujayashree Sangeeta, who is the founder secretary of Bhimavaram Obs and Gynae Society. And currently, ma'am is practicing as an obs and laparoscopic surgeon in Sheshadri Hospital. And ma'am has got too many awards, as well as having so many poster presentations, and also conducting the awareness program Vikasam for the adolescents girl.
Thank you, Mr. Mehul, for that kind introduction. So I would like to move ahead by introducing the program director, Dr. Asha Jain. So Madam is actually the director of SMSA Hospital, Raipur. She is also the director of CPRS, and she is the elected member of CG Medical Council, Zonal Chair, Foxy Food, Drug and MSc Committee. She's also the executive member of ISCCP, ISAR, and Chhattisgarh Fetal Medicine Society. The past offices held by Ma'am are, she was the president of Raipur OB-GYN Society. She has also been the vice president of IMA Chhattisgarh and president of the Rotary Club of Raipur. Madam's current field of interest are, she is interested in saving the uterus, fetal medicine, obstetric and gynec ultrasound, critical care, preventive oncology and colposcopy. So welcome to today's program, ma'am. I request you to please take the program forward.
Thank you so much, Dr. Sujayashree. Namaskar. On behalf of Searchlight series of webinars, specifically Searchlight 19, I welcome all the dignitaries onto this platform. I thank Jodhpur, Jorhat, Junagadh, Kadapa, Kalyani, Katihar, and Bhimavaram Obstetric Gynec Society, and also Delhi Society, which has contributed my speakers and guests to this society, to this program. So I welcome everyone who has joined into this program. I would like to welcome Dr. Dilip Datta sir, Dr. Sunita Malik ma'am, and Dr. Preeti Niranjan ma'am, who have joined in as our guests. I welcome Dr. Sujayashree. I also welcome our speakers, Dr. Sarika Gupta and Dr. Pakhee Aggarwal ma'am, our chairpersons, Dr. B.S. Jodha, Dr. Phukan, Dr. Piyushkumar Vadalia, Dr. Ranita Roy, Dr. Padmalatha, Dr. Laxmi, Dr. Ranjana Jha. I also welcome Dr. Archana Mishra from Delhi Society, a dear friend, an avid robotic surgeon who has actually helped me put this program together. So welcome, Archana. She is also my co-moderator for the panel and has helped me with the panel, and our panelists, Dr. Pranabika Mahanta, Dr. Devraj Bhadarka, Dr. Pramoda, Dr. Suvobrata Sarkar, Dr. Sarafraj Kazi, Dr. Kavita Sirohi, Dr. S. Venkatramana, Dr. Ruchi Bhargav, Dr. Reshmi Banerjee, and Dr. Shruti Bhaskaran. I welcome also all the delegates who have logged in. And with this welcome, I hope this will be a really good learning experience for all of you, because I have thought that the vulva, which is so visible, is actually invisible to us. We just put in the speculum and go directly to the cervix. So today the searchlight is on the vulva, and I hope you will go home enriched by this webinar. So we begin the program as always by praying to the divine. So we would have a short prayer and then proceed with the program. our chief guests and guests of honor for their words of wisdom and blessings to this webinar. First of all, I would like to welcome Dr. Dilip Kumar Datta, sir. He is an MD, PhD at PASCOG, FICMCH and FICOG. He was the chairman of ICOG Foxy in the year 2015, editor of GMA 2017, president INA Bengal 2024-25, and author of 40 books. When I was a very young gynecologist, he was an avid teacher of uterine artery ligature to prevent PPH. So I welcome you, sir, for your words of wisdom to this webinar.
Thank you. Thank you very much for inviting me, because I know that your work and everything. I also know that how you have done your work, police. Also, my thankful to all the speaker and other guests of honors. Today, the subject is excellent, and it is a gateway of our reproductive tract. So thank you for your inviting me. And now I am not moving too much outside, because when I take the charge of the president of the IMA Bengal, it is a headache for me. I'm moving in every week, every corner during election hours. Anyway, when you call me, I always believe that you are just like my younger sister. I cannot avoid you. So thank you very much. Anytime when you call, I am with you. Tomorrow also I'm going to a place. I'll meet you there. So with this, I also again thankful all the speaker, especially our guest of honor. I know each and everyone. Now throughout the age yogi amko, so my movement is quite less now. So thank you very much, my dear sister. I know you are doing a lot of good works, and behind you this sea is also, and area is very nice. Thank you very much for inviting me as a chief guest. Thank you very much.
Thank you so much, sir. Thank you. Now, may I have the CV of Sunita Malik, ma'am? Sunita Malik, ma'am, doesn't need any introduction. She is a professor, senior consultant, unit head, VMMC and Safdarjung Hospital, Delhi. She was the chairperson of Gynec Onco Committee AOGD 21 to 23. She was the chairperson Breast Cancer Awareness Committee AOGD 2016 to 18. She's an executive member of ISCCP, treasurer, World Congress IFCPC 2021, VP AOGD 2015 and 2008, secretary in 2002 to 4, joint secretary Narchi, Delhi 2005 to 7. She has many publications in national and international journals, chapters and books, and her area of interest is gynec oncology. I know ma'am through her work in ISCCP and AGAI, where her focus on preventing cancer in women is really worth watching. I really missed you, ma'am, in ISCCP National Conference in Raipur this year. So welcome, and over to you for your words of wisdom.
Thank you, Dr. Asha, for such a nice, of course, use yourself and Archana Mishra and the very eminent panelists. And the topic chosen, that was the most important thing, the vulva, which, we tend to ignore. So many times we see, even either we don't see it, right, you rightly said, or even if we see, then we tend to refer them to dermatology. Apne aap karte rahenge jo karna, and all, we are not bothered. So that was the thing we should give attention to. And now that special classification is also come, ISSVD classification for vulval conditions, the benign conditions, and when to go for biopsy, when to go for surgery. All these things are going to be discussed in today's program. Thank you very much for inviting me over, and wish you success for your chairpersonship in Pakhee and further, Thank you.
Thank you.
Okay.
Thank you so much, ma'am. Thank you for those really kind words. And now I would like to introduce Dr. Preeti Niranjan Shendonikar, ma'am. I got to know of her yesterday through high praise by Dr. Reshmi Banerjee, that she is a doyen. She is past president of Baroda Obstetric Gynec Society. Her society has received Best Society Rotating Presidential Trophy in her tenure. And she is a credential IMS menopause practitioner, special interest in adolescent gynecology and menopause. This doesn't say enough. What Dr. Reshmi told me was that irrespective of her age, even today, she is out doing camps, making people aware, spreading health for women. So welcome, ma'am, to this program, and we are here to listen to your blessings.
Uh, Thank you very much, Dr. Asha. It was very nice, as Reshmi told me. And I have got a childhood memories of staying in whole Chhattisgarh. And when MP and Chhattisgarh were one state, I did my internship from Bilaspur and I completed my MS from Jabalpur Medical College. So old memories are revived. I always come to Korba and Raipur also and Bilaspur also. And I want to tell only one word of wisdom, as you said. Most of the time, whenever there is some vulval problem, usually patient first goes to the skin specialist. That moment, I always think why we should not get ourselves trained to see the vulva, even for the purpose of eating or any type of complaint by the patient, especially lichen. And I got still one small finding in my memory. I had one patient who had a very small cauliflower, like small growth, just like a pinhead. I sent it for the biopsy and it came out to be the cancer. And then she got the treatment and she was relieved of it. And at the same time, also breast cancer survivor, fine after 12 years. So I'm very much interested in the preventive oncology. Thanks a lot and best wishes to you all. Thank you.
Thank you so much, ma'am. Thank you for being here at such short notice. Thank you so much.
You.
And you are a breast cancer survivor, and you are proud to say that is the way preventive oncology has motivated you. So I think all of us who are here and who are listening should at least examine their breasts and get a pap smear and HPV done for themselves before we actually propagate a lot of things to others.
I will like to add only one line. When I got breast cancer when I was 52, and in spite being the chemotherapy, I never wear the wig, and I used to run my hospital. I wanted to tell patients that still having the breast cancer, you can very well work, and that gives me not only me the confidence to my patients also.
That's the zeal which is there. Yeah.
Still shining on your face, ma'am. The
Thank
positivity.
you.
Thank you so much for being with us. So with this, we come to the end of the inaugural ceremony. Thank you so much for being here. Respected guests, if you have the time and can spare it, we would love to have you here through the program. But if you are busy, we understand. And we would now proceed with the lectures. Over to you, Dr. Sujaya, to introduce our chairpersons.
Thank you, ma'am. So proceeding to the next session, which is examination of the vulva. I would first like to introduce the chairpersons of this session. We have Dr. B.S. Jodha. Sir is a senior professor at Dr. S.N. Medical College, Jodhpur. He has received Marwar Achievers Award. He's been a postgraduate and undergraduate examiner in various universities, paper setter in university exams, national master trainer of various government-sponsored programs, and also has various publications to his credit. Welcome to today's session, sir. Moving forward, we have Dr. Amal Kumar Phukan. Sir is the president of Jodha of OB-GYN Society. Sir is a senior consultant who's trained in laparoscopic surgery. He's the director of Sanjeevani Hospital, Jodha, Assam. We now have Dr. Piyushkumar Vadalia. Sir is not there with us today due to some personal reasons, but I will move forward introducing him. He has done his MBBS from MP Shah Medical College and DG also from the same college. He has a private practice at Vadalia Maternity Home at Junagadh. Welcome, sir. I now request Dr. Amal Kumar Phukan, sir, to please introduce our speaker, Dr. Sarika Gupta, ma'am. Sir, Dr. Amal Kumar, sir, will you please do the honors?
Am I audible?
Yes, sir, you're audible.
Okay. So we are very glad to hear from Dr. Sarika Gupta. She is MD, Senior Consultant, Unit Head, Gynecologic Oncology, Rajiv Gandhi Cancer Institute, Rohini, New Delhi. She was formerly Faculty Obstetric and Gynecology, UCMS and Lady Hardinge Medical College, Fellowship in Gynecology Oncology, Florida Cancer Institute, Orlando, Fellowship and Diploma in Minimal Access Surgery. And she has multiple research papers, and she has an area of interest in sentinel node biopsy in EC. Thank you.
Thank you, sir.
Thank you for that introduction, sir.
Thank you, sir.
I now request
Thank
Dr. Sarika Gupta, ma'am, to please take over.
Can you see my slides?
Yes, ma'am. It's full screen and visible, ma'am.
So I thank the organizers for inviting me in such a lovely conference on vulval carcinoma. So my topic today is vulval examination. And a little bit, I think, because we're talking about vulva, so let's have a slide on vulval anatomy. And the anatomically, the vulva consists of the mons pubis, labia majora, minora, clitoris, and frenulum and prepuce, and the vestibule. But colposcopically, the vulva includes the external, the anus also, and the perineum. Vulval assessment. So vulval assessment includes detailed history taking, which includes what the patient has come for, whether she has itching, pain, or erythema, or any history related to sexually transmitted infection, discharge, menopausal status, about what was her last screening, her psychological history, surgical history, psychosexual symptoms like pain, vaginous plus vulvodynia, and quality of life due to itching. So all these, all detailed history taking about vulva also comes in vulval assessment. And then we come the vulval examination. Vulva should be examined in a very systematic fashion, and the examination of the vulva should start by visual examination of the entire vulval region. Simple examination usually offers adequate visibility of the mons pubis, labia majora, the rim of the labia minora, perineum annulus, but we should do the examination in proper lighting, and we should actually open the labia, separate the labia majora and minora for complete exploration of the crevices and the entire vestibule. This part of the examination is particularly important because it reveals the field of redness, hyperkeratinization, pigmentation, warts, and everything. And then we can do this examination in a more systematic fashion by the 3-ring technique. So what is 3-ring technique? It's a new technique where the 3 vulval rings are described according to histological and embryonic nature of the vulva. The outer vulval ring, as you can see, the outer ring, which is dark pink in color, includes the vulvar skin, the mons pubis, labia majora, and perineum. So first we should look at this outer ring. Then we come to the middle vulvar ring, which encompasses the modified mucosa, the anterior commissure with the prepuce of the clitoris, the interlabial sulci, the labia minora, and the posterior commissure, which is the fossa. The inner vulval ring is glycogenited squamous mucosa of the non-keratinized type, the clitoris, the subclitoris rhombus, the urethromeatus, hymenous remains, Bartholin gland opening, and the Hart's line, and the vestibule. So this is how we do the 3-ring examination. Coming to vulvoscopy, so colposcopy of the vulva is called vulvoscopy, and it's an important part of the gynecological examination. If a colposcope is available, then it's good. If not, we can do it by a magnifying glass also, a dermatologic magnifying glass, which can be up to 10 times of magnification. So even though this colposcopy of the vulva doesn't yield us that much information like the colposcopy of the cervix, because the skin of the vulva is thick keratinized, has multiple stratified squamous epithelium, and the multifocal lesion of the vulval intraepithelial lesion. Nevertheless, that should be done. This colposcopy of the vulva should be done to identify changes of the color, presence of swellings on the surface, and loss of substance of the vulva. It is performed by applying 5% acetic acid to the vulva, and this acetic acid is applied for 2 to 3 minutes. a good quantity of acetic acid is taken in a soap cloth pad and it's applied over the large area of the vulva. And the acetic acid is using not 3%, it is 5% because of the epidermis of the vulva. And we have to wait for 2 to 3 minutes. The colposcopy should begin by the lowest magnification 6 times and to quickly scan the vulva. Then higher magnifications can be used if they are smaller secondary lesions. Now, two things we are looking for in the bulboscopy, the leukoplakia and the astrophyte epithelium. Increase in vascularity stroma manifests as red lesions and decrease in vascularity stroma or fibrotic changes are seen as whitish coloration of the skin. In the presence of anal region, so where the lesion is going close to the anus or inside the anus, it is wise to add a colposcopic examination to the anal canal with the aid of a proctoscopy. Now, now once we apply the acetic acid, we should be knowing that what is normal astro-whitening of the vulva. The normal gradient of skin at the vestibule. So, astro-whitening is seen normally in the posterior vestibule, as you can see in the picture. So, this is normal variation, and the normal variation is also vestibular papillomatosis. We'll come to it. And any inflammatory condition of the vulva, which includes infection or trauma from intercourse, also is seen as astro-whitening. So, that's why astro-whitening is also not a very specific finding. It can be present as a normal variant in the vestibule or it can be seen in trauma from intercourse. What is Pollen's test? 1% toluidine blue is applied to the vulva for 2 minutes. Toluidine blue is a nuclear stain that fixes the surface cell nuclei when applied in blue. All foci of nuclear activity will keep the color and become stained. So all these areas in the picture that shows that there is a nuclear. This may happen not only in neoplasia but also in ulceration, laceration, repetitive changes and parakeratosis. That means that even if a non-malignant, even if whatever erosion is there, that also be colored blue because it has increased nuclear activity. Therefore, although useful, this test is not considered specific enough. The vulvar epithelium is discolored by rinsing with 1% acetic acid and biopsy sampling is done to the lesions which retain the blue color. The stain will be entirely washed away from the normal skin because the surface epithelium does not contain nuclei, and any condition that in the presence of nucleated cells on the skin surface will retain the color and is visible as blue spot. Now, vulval biopsy. The biopsy is mandatory in fast-growing lesions, ulcerations, area of bleeding, and in suspicious changes in the color of the skin. So, the large lesions and multicentric lesions will require multiple biopsies. So, one should take if multiple lesions are seen, we should take multiple biopsies. The area to be biopsied should be infiltrated with lidocaine. You can use epinephrine too. Biopsy can be obtained by using a cervical biopsy forceps or a Keys punch biopsy. So I think a Keys punch biopsy process is a better way of taking the biopsy because we get a 3 to 5 circular biopsy. And small biopsy sites can be treated with Monson solution or silver nitrate, which is hemostasis. Only rarely absorbable sutures are required. And location of biopsy should be indicated by a vulval diagram. So always whenever we are doing a vulvoscopy or a simple vulval examination, if a patient has any kind of vulval lesion, it's important to document and the location of the biopsy, especially if you're taking a biopsy, always document at what place you have taken a biopsy so that if a very small foci of cancer or any other thing is there, then we can take adequate margins later on. Attempt to get a specimen at least 5 millimeter thick. So thickness should be at least 5 millimeters. Documentation. So if we are just doing a general vulval examination, from the patient's phone can be done so that the patient has it for future reference, or if we are using a vulvoscope, we can take an image from the video colposcope. So normal vulva finding. Now these are the two pictures that are showing the normal vulva, and these can be mistaken for abnormalities. That's why I am discussing them. Phukan papilla present in the labia minora near the hymenal vein in this first picture, as you can see. Can show you this here. So numerous ruby and papillae are present in the labia minora near the hymnal ring. These occasionally fuse and coalesce and can be misinterpreted as HPV infection. Taken as HPV. Following the application of acetic acid, a variable extent in normal vulva. This small ring, you can see a whitish area in the second picture. After application of acetic acid, a variable extent of estrovitis develops proximal to the Hart's line, that is the border of the non-keratinized vestibular epithelium and the thin keratinized epithelium of the labia minora. So in between the labia minora and in between this mucosa, we can see a small area of estrovitis. Usually it spreads a few millimeters lateral to the vulvovaginal line on the medial aspect of labia minora, but not extending to the foresheet. So it just ends here, not in the foresheet. This is vestibular papilla, a very normal phenomena where you can see that small villi, papilla are seen, and this is normally seen in 3% of women. Now, Corpuscle and Pixley's classification of colposcopic findings of vulva. So there have been few papers on the classification, like who read scoring and sweet scoring and in cervix. There are two classification for vulva also. However, these are less reliable, so not used usually. The Corpuscle and Pixley's classification use color, blood vessels, the surface configuration, and topography of the lesion. But we are not using this classification. What we are using is the SBD classification to now this classification, which came in 2011, is a clinical approach to diagnosing the vulvar dermatological disorders. The classification includes dermatological conditions with visible lesions and is intended for those who care for women with vulvar skin problems. So the patient with any skin problem or any problem with the vulva usually comes to a gynecologist. So as gynecologists, we should learn about the dermatological conditions also of the vulva, because patients mostly come to us and then we refer to dermatology. And that's why ISSVD has made a classification for both dermatologists and a gynecologist. Now, this classification has 7 categories of lesion. First is skin colored, so very easy classification, clinical classification. So we have classified into 7 types. The skin colored lesions. Skin colored lesions can be papules or nodules. Red lesions can be patches of black. Red lesions can be papules or nodules. White lesions can be white papules or nodules. Dark colored lesions, dark colored patches. And blisters can be sickles or bullae and erosions and ulcers. So 7 categories are there. Now we should learn a little bit about, if we are describing any lesion on the vulva, we should be knowing about the terminology which is used for lesions, skin lesion. So what is a macule? Macule is a flat top lesion less than 1 centimeter, can be of different color is usually of the different color from the surrounding skin. Patch is also flat, but more than 1 centimeter. Papule is elevated, less than 1 centimeter. Plaque is elevated, more than 1 centimeter. Peel is any size, white to pink, edematous, smooth plaque that lasts for less than 24 hours. Nodule is dermal or subcutaneous solid elevations, more than 1 centimeter. Vesicle is blister, less than 1 centimeter. Bulla is the blister, more than 1 centimeter. Pustule is pus filled cavity, less than 1 centimeter. Cyst is more than 1 centimeter. Pus filled cavity. Now, after this, we can actually understand this classification very easily. Now, skin colored lesions are divided into 2: the papules and nodules and the plaques. So, as I've told you, papules and nodules, what are they are raised? They are raised less than 1 centimeter is papule, more than 1 centimeter nodule. What is plaque? This is also raised. Papules is non-raised. So, I have shown very important 1 or 2 pictures also to make it more interesting, even though you can see that I can just tell you that skin colored are the molluscum contagiosum barred, scars, vulval VIN, skin tags, nevus. I've shown 2 pictures. So molluscum contagiosum and what? You can see that they are skin colored lesions, and they usually seen in our OPD. We can see molluscum contagiosum looking like this. So skin colored plaques can be like simplex chronicus and VIN. We will look at those pictures also. Now, red color lesions, plaques or patches. So patches are not flat and flats are raised. So eczematous, now these can be divided into patches, flags can be divided into eczematous lesions um, or patches in flags. So these eczematous lesions have been put in separately. This includes allergic contact dermatitis, irritant dermatitis, atopic dermatitis, eczematous conditions, and some other conditions like Haley disease, extramammary Paget's disease, and other disease which can cause light irritation. The red patches and flags can be candidiasis, psoriasis, lesion pattern. So whenever you see, so this classification is made so that whenever you see a red patch over the vulva, you can see that this is my PD. That is why ISSPD has this classification. Now, atopic dermatitis, you can see there is varying degree of mass, red, black, polymarginated borders, subacute and chronic eczematous dermatitis present as dry scaly erythematous to hyperdermatitis. So, if it is chronic eczematous condition, that it is dry, can be dry scaly also. Otherwise, this atopic dermatitis, that is allergy from panty liners or from deodorant, looks like this. So this is also irritant contact dermatitis from any washes or any washes or used there. Lichen simplex chronicus is lichenification in the form of thickened skin, exaggerated skin markings, and lichen type scale, which is shiny rather than flaking. Okay, this is shiny rather than flaking. This lichen simplex chronicus, this is just shows us the scratch itch cycle that after a long time of itching, this kind of condition develops. Can be dark color, can be light color. Left one, you can see that it is little skin color is little light. Now psoriasis. The psoriasis is you can see that thick plaque of psoriasis is silver, usually silver color. But in case of acute infection, the left one is also showing that it can be erythematous also, but most of the time it is silvery scales. Now, Zoon's vulvitis, also called plasma cell vulvitis. This disease presents a circumscribed glistening of rusty red patches. Now, this is a very, I have seen one, so very typical finding that the complete, vulva is red as shown in the picture. There is purulent discharge, and when we take a biopsy, it shows plasma cell infiltrate in the vulva. Lichen planus presents as a papilloma in eruption with or without mucous membrane involvement. Now, this stria here is called the Bickham stria. And here in this picture on the right side, you can see in the vulva this white lesions and small erosions. This is Bickham stria, very characteristic for lichen planus. And this is itchy condition and can be painful, and irritation can be and can cause severe dyspnea, and but itching is less common as compared to lichen sclerosis. Extramammary prejudice, this is how it is, and it is a rare intraepithelial adenocarcinoma of apocrine gland, can be primary or can be secondary from other cancers in the body, and it presents as an eczematous, like an eczematous erythematous papule or plaque. So red lesions which are like papules or nodules. Now papule here on the left side is the papule folliculitis, right side you can see which is a nodule. So for frontal is a nodule, folliculitis is a papule. See how the difference is papule smaller and the large. Papule, it is a papule, then this is the DD, folliculitis, warts, angiokeratoma, molluscum contagiosum, hidradenitis suppurativa, Haley disease, and nodule. Then this is the DD. I'm not going into details because I have limited time, but I want to show you the picture so that you can recognize these patients come to your OPD, write the diagnosis. Haley disease, a benign familial pemphigus, blister or minor friction causes these kind of lesions, and it is a familial occurrence. So formation of small blisters and erosions by just minor friction and heat. Now white lesions can be papules, so not slightly elevated, can be patches or plaques. So if it is papules is smaller, like you can see here, this Fox disease, it's very trying to gland that resulting in papular inflammation, rubbing and scratching to alleviate symptoms. Is there. Now, like Usually, I take this meat. I think 12.5.
Ma'am, your voice is breaking. Could you come just a little nearer the mic?
Breaking, okay, I will do this.
Yeah, this is
Maybe
better.
now? Okay, now
Yeah, this is much better.
this is better. Okay.
Yeah.
Use of the glans clitoris and loss of the labia minora, along with the whitened flag and crinkled white skin, as you can see, with patches of post-inflammatory hyperpigmentation, indicates lichen sclerosis. So here you can see on the left picture that the prepuce and the clitoris, there is fusion and thinning of the skin. So there are different varieties. You can see in the second one, there is more pigmentation. Some are depigmented, some have post-inflammatory darkening of the skin, and very subtle changes can be seen in the third picture. So this is how lichen sclerosis looks. The labia, there is atrophy of the labia minora. Now, vitiligo to actually differentiate vitiligo from this lichen sclerosis and plainness or other depigmented lesions or the whitish lesions of the vulva. Now, vitiligo is acquired loss of pigmentation. So, and there is irregularly shaped patches of hypomelanosis. The patient doesn't have itching. So, the major thing is that these patients don't have chronic itching. They only come with simpler, there is no texture change. The skin looks normal. No texture change, only depigmentation. So, easy to recognize that this is not any other thing or lichen planus or anything. This is vitiligo. Now, dark colored lesions can be patches or can be papules or nodules. So, which are flat, can be melanocytic nevus, vulvar melanosis. What is melanocytic nevus? Just the dark colored till, which we call. And what is vulvar melanosis? It is multiple irregular pigmentary patches is called vulvar melanosis. Post-inflammatory hyperpigmentation, lichen planus can also cause hyperpigmentation, acanthosis nigricans, melanoma in situ, and dark papules or nodules can be melanocytic nevus, warts, VIN, seborrheic keratitis, angiokeratoma, and melanoma. So this is a picture showing melanocytic nevus. This is nothing just like a pill, and it has variable, can be macule or a papule, means can be macule or a papule. Now, vulvar, this is irregular pigmentation. So, hyperpigmented freckling, very common sight in Indian skin. So, these are benign. This melanoma is cancer, and how to differentiate between these benign lesions and a melanoma is if there is any such, if these are asymmetrical lesions and those with border irregularity, speckling, irregular discoloration. So in these things are there, then it is melanoma. Actually, there is no difference. We have to take a biopsy and then confirm. So if you are seeing any pigmented lesions and you feel biopsy should be take it, don't think that it is just a lenticulosis. Blisters can be vesicle or bullae or pustules. So here we see a classical picture of herpes simplex, where we see small vesicles and very common thing, and it is usually as itching or pain. Lymphangioma circumscriptum, many times ROPD, because it is a sequelae of many times of radiation therapy and surgery. So it is a hamartomas malformation lymphatic vessels, and when the lymphatics are obstructed after surgery or radiotherapy, we can see such kind of many times we take a biopsy and the result comes out to be lymphangioma circumscriptum. Now, LGV, lymphogranuloma venereum. This is the most common clinical manifestation of it is of LGV among the heterosexual in genital ulcer with tender inguinal and femoral lymphnopathy that is typically unilateral. So it is called a BUO. Not seen here, usually very seen in tropical countries, Africa, and the granuloma inguinal seen here. It is an infection, STD caused by Klebsiella granulomatosis. Pain-like lesions and sexually transmitted. Patient anywhere in the body and perineal region and eventually under the central necrosis with clean, sharp, demarcated granulomatous ulcer. Beefy red base that bleeds on contact. Immune blistering disorders with secondary tissue pemphigoids these allergy conditions, you can see either vesicles, like in the left picture, or when the vesicles are break down, then this kind of picture you see in where cicatrization has taken place. Erosions and ulcers. Now, erosion. Now, seventh category is erosion and ulcer. First, we should know what is the erosion, what is the ulcer. Erosion of shallow affecting the epidermis down to the base of the brain, and fissure thin linear skin cell. Erosion is very superficial. So, also is a deeper defect affecting the epidermis and some or all of the dermis. Now, erosions can be these excoriations, erosive lichen planus, or fissures. Ulcers can be abscess ulcer, chronic Crohn's disease, herpes virus infection. Now, let's see these ulcers. Now, the shafts of chancre or the chancre caused by HB and is acute sexually transmitted disease that was a very painful and regional lymphnopathy, very uncommon nowadays. We have all read in the books, seen patient failure. Syphilis chancre, not seen, solitary painless ulcers, and with raised sharply demarcated border and little exudate. This is important. Many patients are coming. We have seen many patients with this condition, fissures. So these are paper cut lesions. Now, I think if you can appreciate here, there's a fissure. There's a fissure in the foresheet here. Then there's a fissure here. So these splits that can occur anywhere on the vulva related to a variety of conditions. Then they are not diseases, but rather a manifestation of problems in vulvar skin that may be difficult to solve. So there are many causes of fissures, eczematous disease, seborrheic dermatitis, irritant dermatitis like sclerosis, Crohn's disease, candidiasis. So infectious disease, non-infectious disease, many causes of fissures. If a patient is showing us, so they typically to actually point that this is the painful condition. So if they are showing us, if the patient is present, we have seen it in the vulvoscope, then we should actually pull out all these causes. Abscess ulcer is a painful ulcer, points out shallow, well-defined ulcer with fibrinous base and somewhat erythematous border. Edema is also another category. The edema can be skin colored or pink or red. Now, this is the vulval manifestation of Crohn's disease. Now, there is chronic edema and abscess in the vulva in this condition, and there are these deep fissures in Crohn's disease, as you can see in the right picture. The pathology shows non-caseating granulomatous disease, and the symptoms are of Crohn's disease, and these patients get treated by giving treatment for Crohn's disease. Now, just this last slide about the histological classification of vulvar dermatosis. Now, I have discussed the clinical classification till now. There is another histological classification where if we take a biopsy and we see a spongiotic pattern, then this is what we are thinking, whether it is dermatitis, allergic or contact dermatitis. If a acanthotic pattern is seen, then this patient might be of psoriasis, lichen simplex, primary or secondary. And if it is lichenoid, the pathology is coming out to be lichenoid, then this is the TD. So this is how they have made a classification for the pathologist and also for the clinician, so that if granulomatous pattern is coming in the vulval biopsy, then it can be Crohn's disease or this Malcolm-Rosenthal syndrome. So this is how we make a diagnosis of vulval dermatosis, and hopefully that you have learned something from this presentation. Thank you.
Thank you for that very informative talk. I now request Dr. Jodha to please give a few remarks about this presentation. So Dr. Jodha and Dr. Amal, both of you can say a few words. So Dr. Amal Kumar Phukan, sir, would
Hello.
you please add a few remarks?
Yes. Can you hear me?
Yes, sir, you're audible, sir.
Okay. It was an excellent presentation. So a lot of new things she has told us, and I think all we are benefited. Regarding this carcinoma vulva, I just want to know what is the incidence of carcinoma vulva? In recent times, is there any increase in the number of carcinoma vulva, and if there's any reason for that?
Sir, the vulval cancer is a very rare cancer, and the incidence is, I think, 1 to 2%. I don't remember exactly. I think Dr. Pakhee will tell us now. And no, it is. I don't think that it is going to increase because of the vaccination and the screening now we are doing, and the patients have access to gynecological examination, and then we can catch the patients in the pre-invasive stage. But till now, yes, as cervix cancer was very high in our country, so as the HPV infections are very common, so till now, yeah, vulval cancer was very high, but it is going to reduce in the future. I hope so, and I think that is going to happen.
I think it's a message that HPV vaccination, which now we are giving, so it is going to reduce the incidence of carcinoma vulva as well.
Jodha
Okay.
sir, Jodha sir,
Thank you.
to say something?
I'm just came out of that rally just because of very much loud sound. That's just I'm on the road, just walking through.
Yes,
The
sir.
presentation which I heard was really at least 10-15 minutes only I am able to hear that. But the real problem which we see in our OPD is where the advanced age patients who are post-menopausal suffering from these sort of problems, and most of the gynecologists are not aware of how to take care. Most of the times we are referring these to the skin and venereal disease specialists to dermatologists to go through them and to diagnose them. So the presentation which has been given, and the message that gynecologists, if well aware of the things, they can at least have an idea of whom the patient we can diagnose and treat, and what are these patients which can be taken care by the other specialty to avoid these type of situations which we face. And with the advancing age, the number of patients of malignancies and other complications are rising, and they are reporting. But the sufferings are much higher in this group of patients because the relief in symptoms is really a challenge for the dermatologists and also gynecologists, because these are the patients who respond very less to our therapies, and they suffer more during their lifetime where they have these types of problems. So thank you very much, Dr. Asha Jain, and best wishes for your future endeavor, and best of luck, and thanks to speaker who has given an excellent talk. Thank you very much.
Thank you, sir.
Mr.
Thank you so much. Yes, Dr. Sujay.
Yeah, so moving
Thank
ahead.
you, Dr. Sarika. That was eye-opening and really very concise. Thank you.
Thank you, ma'am.
Thank you.
Very concise and very. Thank you, ma'am. Thank you so much. So moving ahead to the next session, we have a session on vulval intraepithelial neoplasia, where the speaker is Dr. Pakhee Aggarwal. I would like to introduce the chairpersons. Firstly, we have Dr. Ranita Roy Chowdhury. Madam is the Associate Professor, College of Medicine and JNM Hospital, Kalyani, Naidya. She's also the President of Kalyani OB-GYN Society, and her fields of interest are high-risk pregnancy and urogynecology. Welcome to today's session, ma'am. Next, we have Dr. Padmalatha with us. Madam is the elect President of Kadapa OB-GYN Society. Welcome, ma'am. We have Dr. Laxmi Sen with us. Madam has done her MBBS from DMCH, Darbhanga, Bihar, and also MS from the same institute. She has served as a doctor under Bihar government for 35 years. She has 42 years of experience in OB-GYN, and she has memberships. She's a life member of IMA and also a FOXY member. So welcome to today's program, ma'am. We also have with us Dr. Ranjana Jha. Madam is a consultant gynecology at Katiyar Seva Sadan. She's also the Vice President of Katiyar OB-GYN Society, Vice President of the Indian Red Cross, Katiyar. So Madam is also received the Corona Warriors Award by IMA Bihar chapter, and she has also received IMA National President Award. Welcome, ma'am, to today's program. So I would request one of the chairpersons to please introduce the speaker, Dr. Pakhee Aggarwal, ma'am. Anyone can please introduce the speaker, Dr. Padmalatha or Dr. Laxmi.
I'll introduce the speaker. Good evening, everyone. Dr. Pakhee Aggarwal. She is a Commonwealth Fellow and UICC Fellow, Gynae Oncology and Robotic Surgery, ESDO and SRG's Robotic Gynae Oncology, Belgium. She is a former assistant professor from LHMC, New Delhi, former senior resident in AIMS, gold medalist in OBG from Maulana Azad Medical College, New Delhi, executive board member, Association of Commonwealth Scholars and Fellows, India, attended over 180 national and international conferences, delivered over 70 guest lectures, authored over the 60 publications in national and international journals and book chapters, author of book Handbook for MRCOG Part 2 Examination, invited expert for ICMR and RCOG as faculty, trainer and examiner, areas of specialization, robotic and minimally invasive surgery and gynec oncology. Yeah. Welcome, Dr. Pakhee Aggarwal.
Requesting Dr. Pakhee Aggarwal, ma'am, to please start the presentation.
Yes, thank you, Dr. Padma, Dr. Asha Jain, and Dr. Archana Mishra, and the entire team for having me. I'll be talking about VIN, and I will try to keep to my 20 minutes and touch on the salient clinical aspects of VIN. All right, so I just want to know that it is visible. Is my presentation visible?
Yes, ma'am, it's visible.
Yes, ma'am.
Thank you. Right, so I will be talking about VIN, and briefly I will cover it under these headings. What is VIN? What has been the change in terminology since we started learning about VIN and what it is now? What is the basic pathology behind it, the risk factors, what is the natural history, how it presents, how do we diagnose it, how do we treat it, and then how do we follow up after treatment, and few special situations also. Now, VIN very simply it stands for vulval intraepithelial neoplasia. So it's a pre-malignant lesion of the vulva, and unlike for CIN, there is no routine screening method for VIN. Now, ISSVD, Dr. Sarika mentioned briefly, so it's the society which comes up with these terminologies. And when we were in college and we were studying the classification we used to follow was VIN1, VIN2, VIN3, carcinoma in situ, and differentiated VIN, which was the initial classification. I'll not go into the details of the middle two ones, but suffice to say that now we do not use these terms anymore because VIN1 has been replaced by LCIL of the vulva, which is also called as flat condyloma, and it is linked to HPV very greatly. So just like CIN1 is linked to HPV and coilocytic changes and all of that. So VIN1 has been replaced by LCIL. VIN2, 3 and carcinoma in situ have been replaced by vulvar HCIL or high-grade squamous intraepithelial lesion, which is the usual type. And then there is something called as differentiated VIN, and I'll just come a little bit later in the presentation on how it differs from the HCIL and the LCIL of the vulva. So the LCIL is basically an HPV-related intraepithelial neoplasia, and it more or less replaces what we used to call as VIN1. HCIL of the vulva is also called as usual type of VIN, or VIN2, 3 come under HCIL. The same way CIN2, 3 come under HCIL of the cervix. Then differentiated VIN is the lesion which is not associated with HPV. So here I'd like to point out, as we were talking about HPV vaccination preventing vulval cancer, this type of VIN and leading to vulval cancer will be the small subset of patients who may not benefit from the vaccination because these lesions are not HPV associated. They are usually associated with vulval dermatosis like lichen sclerosis. And that is why it is also called the VIN simplex type. Now, in the basic pathology, we all know LCIL. When it is LCIL, it is the lower third of the epithelium. When it is the VIN2, then it is also the middle third, and then the full thickness is involved right up to the upper third. Then it comes under the VIN3. And when it breaches the mucosa is when it becomes frank cancer. So it is the same classification here as well, except that we now call it LCIL and HCIL. And these are the usual types of the VIN, so vulval intraepithelial neoplasias. The differentiated ones are slightly different because they are, like I said, we call them simplex. They are not associated with HPV, and the epithelium becomes thickened and parakeratotic, and it is basically confined to the parabasal and the basal layers, and there is no atypia above that layer. So it's only in the lower part. So the risk factors to develop VIN, or let us come to the right terminology, VHCIL is HPV, like I said, and 90% of these lesions will test positive for HPV if we were to do an HPV test for them. The LCIL type, which is VIN1, is usually associated with the low risk types of HPV, which are 6 and 11. And the HCIL1 is associated with the high risk types like 16, 18, and 31. And usually, because HPV is a multifocal disease, they are associated with either CINs or vaginal intraepithelial neoplasia. The HCIL, the HPV-associated vulvar HCIL is more common in the premenopausal patient, while when we look at the postmenopausal subset, the vulval HCIL is not so much linked to HPV. Now, there are other risk factors as well, such as cigarette smoking and immunodeficiency. For the differentiated VIN, like I said, HPV is not a risk factor, but lichen sclerosis is. And the cumulative risk of someone developing vulval squamous cell carcinoma on a background of lichen sclerosis is as high as 6 to 7%, which is quite high if we see the natural risk. Now, the vulval LCILs are usually self-limited and they would resolve in a year or two. The same way CINs, we say, have a very high resolution rate in the cervix. The HCILs are the ones which will tend to be multicentric, and they are associated with 20% of the STCs of the vulva are HCIL going on to develop STC. The differentiated ones are usually unifocal and unicentric, but although they are rarer, their risk of progression to squamous cell carcinoma is much higher. It is to the tune of 33%. And there is no specific test or biomarker that will tell you that this is the subset that is going to progress to become STC. So the same like in HPV of the cervix-related progressions, we know we have come up with certain biomarkers. For the vulva still, that is an area of research to tell us which of these, especially the ones which have lichen sclerosis, they have a very high risk of progression. Now, the clinical presentation, they could be asymptomatic and incidentally detected at a gynae checkup, especially the LC. But when they are symptomatic, the commonest symptom is a vulval pruritus. There could be vulval pain and burning. There could be dysuria if it's a periurethral lesion. Sometimes the patient may just notice a lesion or an elevated area or a plaque or a nodule. And sometimes we may detect it when we do a cytology that is abnormal, but we don't see anything on the biopsy. So it could be a multicentric disease with no presentation of the vulva. Now, when we evaluate these patients clinically, we need to know their history, whether they've had vulval SILs in the past. Is there any history of genital warts, any cancer which has been treated, any other HPV-associated CINs or veins, smoking, immunosuppression, and if they have already been vaccinated to HPV. On the examination, Dr. Sarika touched a great deal about it in details. It's important to inspect, to palpate, and also look at the groin for any lymph nodes. So look at the color changes, look at the mass, look at the ulceration. And the common differentials of a VIN could be other types of warts like condylomas acuminata. For the vulval HCIL or the differentiated one, there could be STC which is coexisting, which may present as a plaque or an ulcer or a nodular body mass. And other lesions, if you are not very used to doing a vulval examination, you may confuse them with lichen sclerosis, lichen planus, condyloma, lata. And we saw a good deal of slides earlier to this on what are the salient differences between them if you do a proper clinical examination. Pruritus as a symptom may be present in dermatitis, in molluscum, in the various lichens, and even in herpes simplex. So those are the common differentials that one would need to differentiate it from. Now, these lesions are usually raised and they are verrucous. They are usually white, but they could also be red, pink, gray, or brown. So on the left, you see the lesions which are raised but white. In the middle one, there is a brownish kind of lesion, and in the last one, it's a pinkish lesion. And most of them would occur between the 3 and the 9 o'clock distribution. That's the most common site of the VIN or the vulval SILs, I should say, happening. Now, to diagnose, whenever you are not sure of the diagnosis, the only way to clinch the diagnosis is to do a biopsy. And the way to do, you saw already about the colposcopy. If there is no visible lesion, but the patient is constantly symptomatic of either pruritus or vulval irritation or pain, then you combine it with a vulvoscopy, which is a colposcopy of the vulva, using acetic acid, using toluidine blue to highlight the areas which are not visible to the naked eye. If there are multiple areas of abnormalities, then it is a good idea to take multiple biopsies. And if you have been empirically treating a lesion, which many patients are also want to do themselves, is that they self-treat with steroids. And when they are treating it, it gets all right. And the minute they stop the steroids, the ointment, that's one of the most overused over-the-counter medication, steroid ointments for vulval dermatosis. And so when they stop using it, the lesion starts off again or the itching starts off again. So those are also the patients who should then no longer be treated empirically and should have a biopsy. Best way to take it is the squeeze punch. It comes in 3 sizes, 3 mm, 4 mm, 5 mm. You pick the size appropriate to the lesion. It's inserted in a twisting manner under the skin. As soon as it breaches the skin and it touches the subcutaneous tissue, there is a definite give in the tissue. And then when you pull it out, you've got a nice core of tissue which comes out. And usually they don't bleed, but yes, if there is, you can put in a small suture. Now, what about treatment? Once you have confirmed that, yes, it is one of the LCILs or the HCILs, what should you do next? Now, LCILs generally don't need to be treated unless they are symptomatic because, like I said, they have a very high self-resolution rate. The HCILs are treated with either excision or ablation or topical treatment, which is pretty much what we also do in the cervical HCILs. So either we ablate them or we excise them or we do some other kinds of treatment. Not so much in the cervix, the topical one, but here we do because this is outside the body. The aim of treatment is basically to prevent the progression to squamous cell carcinoma, to relieve the symptoms if they have, to maintain the anatomy as far as possible and the normal function. So how do we choose options is that if it is a raised lesion, it is ulcerated, and you think that the possibility of SCC is high, for example, on a background of lichen sclerosis or there was a previous vulval HCIL which was being treated, or if there is immunosuppression, then it is a good idea to do a biopsy, and more so, or excise it, basically do an excisional biopsy, and more so if it's a single lesion. Usually, if the lesions are multifocal, one option is to do a biopsy. But if you think that the possibility of SCC is not that high, you could ablate them initially, especially if those lesions which are close to the vital structures like the clitoris or the urethra or the anus, where you would excision would be very disfiguring and uncomfortable for the patient, and where you think that the SCC, it is not a frank SCC. If it's a frank SCC, none of this applies. They need to have the radical vulvectomy as they would. But if it is a pre-cancerous lesion you are thinking, then you could. And especially if you've already taken a biopsy earlier and you know that it is not cancer and it's a lesion which is recurring, you could also give a trial of ablation rather than re-excising that lesion. The topical treatments are usually for clitoral lesions or those who are not willing for either excision or ablation. They are okay with a long-term therapy because topical therapy can go on up to 4 to 6 months. And those which are having recurrent lesions and they're just tired of all the options. VIN is something we don't see all that common in India. It is commoner because patients are now becoming aware of it. But in the UK, I think when I was there, every third lady who was over the age of 70 or 80 came with a vulval dermatosis, and they were being treated long term and being followed in the vulval clinic. Now, excision as a modality of treatment is both diagnostic and therapeutic. The idea is to have a margin of at least a centimeter, but at the same time preserving the anatomy and function of the vulva. The depth has to be up to the epidermis, and you can include a small amount of dermis to exclude underlying invasive disease. In the HCLs, which are usually multifocal, so when we do a wide excision and the negative margin is negative, so it reduces recurrence risk at that site, not elsewhere on the vulva where it may arise as a de novo lesion. Sometimes a procedure called a skinning vulvectomy may be required, which is removing the vulvar skin along an avascular plane beneath the epidermis, preserving the subcutaneous tissue. And this is generally reserved for patients who have very extensive lesions or multifocal lesions that are very, very symptomatic, have already tried other treatments like topical treatments or laser ablation. All of those have failed. Then it makes the case to remove the entire vulva, but at a superficial level, not going up to the depth of the subcutaneous tissue. And so as for VIN per se, the simple vulvectomy or a total vulvectomy, which is removing the entire vulva with the perineal tissues, is not a procedure that is done very commonly for VIN. It is something which is done in cancer patients. To ablate, you could do a CO2 laser vaporization, you could do an argon laser, or you could have a PUSA, which is an ultrasound surgical accelerator. It is important that before you do any kind of ablative procedure, malignancy has been excluded. And how would you exclude the malignancy? By ablating, by doing the colposcopy, by doing the colposcopically directed biopsy of that area. This generally requires special training. It requires special equipment. You need to have special goggles. The OR is separate. And it is, what is the depth of destruction when you ablate? It should be 1 millimeter in the non-hairy and 3 millimeter in the hairy layers of the vulva to get to the appropriate depth. And when there are multiple small lesions, it's a good idea because you can exactly pinpoint that small lesion, ablate it, go on to the next one, ablate it, go on to the next one. And usually one cycle is enough. And if it's a superficial ablation, then cosmetics is not so much hampered. It's better than doing an excision. But if you have to do a very deep ablation and that too at multiple points, then there can be scarring when the skin heals. So that can be disfiguring to the vulva. Topical therapy is generally for recurrent lesions where you are not suspecting invasive disease. So the treatments which are given are an imipramod cream, which is an immunomodulator. You apply a very thin layer on the lesion 3 to 5 times a week for as long as 16 weeks. And we reassess after 16 weeks to see whether there is response or not. If it touches the skin around it, there can be erythema, there can be erosion. So patients have to be very motivated for this kind of therapy and able to apply it. Other options which are there are 5-fluorouracil, which causes a kind of chemical desquamation of the axil, but leads to a lot of pain and scarring and ulceration. Then other drugs are there like cidofovir, which are experimental. And various studies have been done with these drugs because the women who have VIN, they generally have it as a very kind of a chronic illness. And so the response rate for these therapies stands at about 50 to 75%. So if I have to just sum it up kind of in a nutshell, how to prove to choose the best option. So once you have a biopsy proven axil, then when you do the physical examination, do you think that there is concern for invasive disease? Meaning, is it a raised ulcerative lesion which has irregular borders? If yes, then go in for excision and do a wide local excision with at least a centimeter of margin. So that you can, because once we fix that, formalin fix, when it's a 1 centimeter margin, when you fix it with formalin, it usually comes down to 0.7 centimeter. So you don't need to do a radical margin like we would do for vulvectomy, which is a 2 centimeter margin. So, but a 1 centimeter margin is definitely needed if the concerns are there that you may be missing malignancy. If you don't think that the concern for malignancy is very high, then again reassess the patient factors. Is he immunosuppressed for any lesion? Has there been lichen sclerosis in the past? Is it a differentiated kind of VIN? If yes, then again, because like I said, lichen sclerosis and DVIN, they have a higher rate of progression to SCC. So excision is the preferred modality for these patients. If not, then look at the site of the lesion. And if it is a lesion which is involving the clitoris, urethra, or anus, then if it is not involving these vital structures and you think that you will be able to excise it, go always for excision upfront. If not, then go in for the alternate methods of ablation or topical therapy. And same, if the lesion is involving the clitoris, urethra, or anus, then prefer ablation over topical therapy. And it is ablation first and topical therapy as the second line. And once they have been treated for VIN, then a gynae examination should go on every 6 months for at least 5 years and then annually. Now, after you have treated and when you are doing this surveillance, irrespective of the modality of treatment, whether you have done an excision or an ablation, 1/3 of the patients will have a recurrent SIL. And the risk of recurrence with progression to invasive carcinoma is 8%. There are certain factors which increase the risk of recurrence, like immunosuppression, having multifocal or multicentric disease, if it's a very large lesion, if they are elderly, postmenopausal, and if they had positive margins on the initial excision of specimen. Smoking again is a risk factor. So these are all the women who could have a higher risk of progression, even higher than 1/3. So that is why follow-up needs to continue for a long time, for even up to 5 years or longer. And it's usually a visual inspection which suffices, because if you have been following them up regularly, then you know you would have drawn the diagram, marked out a lesion, but also colposcopy and biopsy as you deem fit. So HSIL has a 2 to 15% risk of SCC, again to reiterate this fact, and differentiated VIN has a 33% risk of SCC. Now, few special situations in pregnancy, if you detect HSIL, then it's important to first exclude malignancy. If you have excluded malignancy, then if they are close to term, then defer the treatment postpartum. If they are remote from term, then either ablate or excise the lesion. There is no role of any topical therapy in pregnancy because they are all immunomodulators. They are DNA toxic agents. If it's an HIV positive patient, then and the lesions are usually they tend to have very scattered lesions and very extensive lesions in the clitoris, urethra, anus. So you need to do a kind of very thorough examination for these patients. And again, excision and ablation would be preferred over topical therapy, reserving it only for the recalcitrant cases. So to conclude, the latest ISSVD terminology classifies the previous VIN as LSIL, HSIL, and DVIN. LSIL is self-limiting and it is not precancerous. HSIL is multifocal, usually associated with HPV, and a risk of progression to cancer, which I said could be 2 to 16%. DVIN is multifocal. It is not HPV associated, although it is less common. It has a higher risk of progression to cancer, up to even 33%. The treatment for VIN includes excision, ablation, and topical therapy. The goals of treatment are to prevent the progression to SCC, to relieve symptoms, to preserve anatomy and the function. And despite the best of your treatment, 1/3 can recur, and hence long-term surveillance is a must. Thank you very much.
Thank you. That was great, Dr.
Nice
Pakhee.
presentation.
Yeah, thank you, ma'am, for that
Yeah.
presentation. I now request the chairpersons to please make a few concluding remarks.
All the three chairpersons are here, so I request them to comment one by one. Dr. Laxmi.
Ma'am, Dr. Padmalatha, Dr. Laxmi, Dr. Ranita, ma'am, please, few remarks.
Yeah, Dr. Pakhee, you have covered very well the entire topic within the short time. I think in 20 minutes you covered very well.
That was allotted to me 20 minutes, so I made sure I finished in 20. Otherwise, it's a huge topic.
Yes.
But the message was conveyed, ma'am. That's what counts.
Yeah.
Yes, ma'am, I would like to say that this was a very, you have discussed the topic very well, and it was very enrapturing, and we could just get the whole thing in a nutshell. And it was very enriching to be in this session as a chairperson. I would like to thank all of them, and I would also like to congratulate the speaker on his wonderful discourse on vulval lesions. Okay, thank you so much. Thank you, Dr. Asha Jain.
Thank you, Dr. Ranita. Laxmi ma'am, would you like to say something? Dr. Laxmi Sen.
Madam is there, but I think she's so.
Dr. Pakhee.
Thank you so much, ma'am. Yeah,
Dr. Pakhee and Dr. Sarika, both of you were very outstanding, ma'am. It was a pleasure to listen. And the target of these webinars is you can't learn everything. But if you get an interest in actually having a look I think we'll teach ourselves after that. So it was really, really very good. And thank you so much. Thank you.
Thank you, ma'am.
So, Sujaya, should we proceed?
Yeah, yes, ma'am. We'll proceed with the panel discussion. Mr. Mehul, please can you share the panel discussion is case-based vulva disorders, where we have Dr. Asha Jain and Dr. Archana Mishra as the moderators. So we've already been introduced to Asha ma'am, who requires no introduction. So introducing Dr. Archana Mishra. Madam is a professor. She's been affiliated to VMMC at Safdarjung Hospital, New Delhi. Madam is the organizing secretary of IFSCP. She's also the executive member, Gynec Oncology Committee. She's the executive member, Safe Motherhood Committee. So Madam has numerous awards to her credit. It's a great honor to have you with us here today, ma'am. I request Dr. Asha ma'am to please introduce the panelists.
So we have these 10 panelists. Dr. Pranabika Mahanta, Secretary of Jorhat Obstetric Gynec Society. Dr. Devraj Bhadarka. He has a diploma in endoscopy, director of Earth IVF Center, and he is the secretary of Jamnagar Society. Not Jamnagar. Junagadh Obstetric Gynec Society. We have Dr. Pramoda Reddy ma'am, who is the secretary-elect of Kadapa Obstetric Gynec Society. Dr. Suvobrata Sarkar, secretary of Kalyani Society. Dr. Sarfaraz Qazi sir, who has kindly consented to join this. President of Himmatnagar Obstetric Gynec Society. Dr. Kavita Sirohi. She is the director owner of Sirohi Medical Center, Faridabad. And she asked me a question of the vulva and I just pulled her in. So welcome, Dr. Kavita. We also have Dr. S. Venkatramana sir, who is the president of Kurnool Society. I just met him at the managing committee. Welcome, sir, to be in this panel. Dr. Ruchi Bhargav ma'am. She is from Jalandhar and she's been an expert, and this is her third stint with me. She's an MD from Government Medical College, Amritsar, and director of Bhargav Advanced Gynec Surgery and Cancer Center, Jalandhar. Welcome, Ruchi ma'am. Dr. Reshmi Banerjee just messaged that she's going out for a surgery. She is the secretary of Baroda Obstetric Gynec Society. She does great embroidery, but she didn't send me pictures. We also have Dr. Shruti Bhaskaran, who's the professor, Department of Gynae, UCMS and GTB Hospital. AOGD, she's the web editor of AOGD, and her areas of interest are gynec endoscopy and oncology.
So now this is the appeal on behalf of Dr. Asha Jain ma'am. Ma'am is actually standing for the Committee of Food, Drug and MSc. So we have the nominations coming up in May. So we request all the presidents and secretaries who are present here in today's program to please nominate ma'am on behalf of your society. You all know that madam is an academician, so she will do a lot of good to the committee. Thank you all once again, and we proceed with the case discussions.
Thank you so much, Sujaya. Thank you for making my appeal. Please do nominate me. The nominations will reach you in the first week of May on your official email IDs. Kindly do nominate, and I will be sharing the nomination details with you. Dr. Archana ma'am.
Hello, ma'am.
Yes, dear. You're taking the first case. Over to you.
Ma'am, our sites will be scrolled by somebody else.
I'll do it.
Okay, ma'am. That's good. That's good. So first, I would like to congratulate Dr. Sarika and Dr. Pakhee. Very lucid presentation. And we have talked about pre-invasive lesions. We have talked about how to examine the vulva. So now I will be taking a little bit benign topic. These are the topics which most of the gynecologists, even MBBS people, are seeing in day-to-day life. And we should be very clear how to proceed with these cases. These are simple cases, but their number is a bulk. These cases make a lot of our OPD. So we should be very much clear how to proceed with this case. So my first case is a 27-year-old unmarried girl. She is working in a PSU. She is sexually active. She is having some bumpy lesion on vulva for 5 months. Very small lesions, and they were painless. Ma'am, next slide. So this is a picture. These are skin-colored, grainy, bumpy lesions. These are non-tender. The girl noticed it, and then she came to us regarding these lesions. Next slide. So my first question goes to Dr. Ruchi Bhargav. Ma'am, what do you think these lesions may be?
Good evening, ma'am, and thank you for inviting me here. It's always a pleasure to be here. These lesions, they look like condyloma acuminata or genital warts, as we commonly say.
So, ma'am, how will you like to manage this case? This girl is very anxious. She's sexually active.
She's
And
unmarried,
she's saying
sexually
that, ma'am,
so first of all, we have to make her aware that this is a sexually transmitted disease and the cause is HPV virus. So we have to make her aware how she contacted it. It could be due to unprotected vaginal intercourse, anal intercourse, or even oral intercourse. So we will have to guide her that this is a sexually transmitted disease and she will have to look after herself, because at present she has got this, but she can get other STIs also if she is not careful.
Yeah, ma'am. Please, next slide, ma'am. So, ma'am, that is very nice about counseling. You should be telling the patient what she is suffering from and how she has contacted it. But she is very much worried about these lesions. So, ma'am, next slide, please.
So she
not display the answers first.
Okay. So, Ruchi, ma'am, I was asking about the patient is worried about her management also. So,
yes. So first we will have to teach her about. We will have to see these. They disappear for some time, but they recur also, and they have a very long incubation period. So we will have to tell her that they can recur and they may not be permanently cured. But because she is in trouble, we have to give her some immediate relief. So that is in the form of, first we have to teach her about being safe. Second, we will have to teach her about vaginal and vaginal hygiene, and then comes the role of drugs. Commonly used TCA, BCA, they were the commonly used drugs initially. Now we have, and bodophyrotoxin also, but now we have some immune modulators also like imiquimod, which increase these are applications which increase the immune activity. And of course, interferons are also in a role today where they can be given intralesionally or they can be given systemically also. And of course, there are some surgical procedures, and surgical procedures may be laser ablation, surgical procedures can be excision, they can be cryoablation, and they can also be simple ultrasonic aspiration if there is collection.
Very well said, ma'am. So first thing is that she's anxious about her lesions. So we have to treat her because it is affecting her body image. So we have to tell her that it may recur. She may get other infections also. She has to be careful. But presently we have to follow with this. She opted for the self-administered management. We have given her this thing. For 2-3 sittings, we have given her trichloroacetic acid and she was relieved of that. Most of the lesions were gone. Next slide, ma'am. So, Sir Venkatraman, I think you are there in the panel. You are there. Sir, what will be your counseling regarding the sexual relationship and condom? She's an unmarried girl. She's not very, open about that, whether she is having one sexual partner or multiple sexual partner, or she will be seeking another partner. First, she is worried about the present partner. She has come along with her boyfriend and the partner was also a little bit worried. So how should we counsel her that will condom will be enough, whether the partner will also be needing treatment?
Condom is useful for to prevent any STD, sexual transmitted disease. And we have to advise about the
sexual life also. I mean, if it is a single partner or multiple partners, that will be different. So whoever may be the condom used by the sexual partner is very essential to prevent any STIs.
Sir, what about treatment of partner? The boyfriend is asking, I'm
Partner
simple.
also, it is better to take treatment, madam. It is better to take partner also.
But he is not having any symptoms. He is not having any warts. He is asymptomatic. He is asking, what should I do?
No, empirical treatment you can give, madam. Partner also, prophylactic, to prevent the STIs.
Of course, sir, counseling is very important. We have sent them to our skin and VD clinic, and we also have this thing, counseling, VTCT and everything. So sexual partner, if symptomatic, then treatment according to guideline. If asymptomatic, only counseling. And partner might has already had HPV, which is asymptomatic at present. There are not any visual warts at present, but he may develop in future.
Okay.
And no HPV testing, only physical examination is required. And the other STDs should be screened for, because the couple was not very open about the relationships. And if girl is seeking a new partner, it's better that he should be informed about this thing. So that is the way we proceed. So we counsel the patient like this. So Asha ma'am,
Archana, I have something to add. How can you inform the new partner? Is it not the breach of the privacy of that patient?
Ma'am, we are nobody.
A medical legal problem, because you don't even know whom she's going to see. You just have to advise her that you have to.
Yeah.
But because we cannot do it, we are not responsible.
We are not doing it, ma'am. We are not doing it. The girl
condom does not protect against HPV, because HPV can be transmitted in spite of a condom.
Vaccination, role of vaccination, ma'am, in boys?
Vaccination should be there. Vaccination should be there. Dr. Sarfaraz, sir, you want to add something to this case?
Yes, boys also should get vaccinated. And it is in UK, it is compulsory for girl and boy both once they are attending school.
But you are not audible clearly. Can you just...
there is some background noise in your...
Hello.
File.
Okay.
If it is two devices, you need to do something about it, or place your mobile a bit far away. There's a lot of disturbance.
Okay, I have to change the device. Let me change first.
So, areas not covered by a condom can spread the HPV. So,
ma'am, can I add something?
Yes, please go ahead. Put on your camera, please.
Ma'am, it's on. It's on.
You're visible, Shruti.
Yes. I just wanted to say that we can tell the woman that even if we treat the warts, she should not think that she is not HPV infected anymore. So there comes the importance of counseling her, to tell her for the future partners also, because it takes time for the HPV to go. And regarding the vaccination, what they say, it's Gardasil 9 is what is recommended. And once warts develop, it cannot prevent warts. So it is only a preventive vaccination. So sometimes we say that even after the patient is in cases of CA cervix and all, in the sense when we are giving it for cervical cancer, we can give even if the patient is pre-invasive lesion, if she is having. But in cases of warts, what they say is it's only preventive. So if she doesn't have warts, only then we should advise vaccination.
Shruti, I would like to add something. Gardasil 9 is preventing 9 infections.
Yes, ma'am.
If you see epidemiology, there is less than 1% chance that the person will be suffering from all 9 infection. So even if she is suffering from 6 or 11, which is causing warts, it will provide protection from rest of the 8 infections. Or if she's suffering from 2, then at least rest of the 7 infection. So you have to counsel her that you are already having infection from this thing.
Yes.
But
only from CA
if you
cervix.
take a vaccination, it will be preventive against rest of the HPV, because we are not having very clear idea what she is, her sexual history is like that. She may be seeking new partners, and she may be getting infected and reinfected also from some of the viruses. So role of vaccination is of course there, but the only problem is that regarding the partner, presently we are not having Sarvavac is we are seeking that it should be provided to the boys also. But till now in India, it is recommended only for the women and girls, not for the boys.
Can
So
I add
we
something?
have
Archana,
already
there is
discussed.
a change. There is a change.
Ma'am, Sarvavac is, yes, ma'am.
It is licensed for boys and girls up to the age of 26, but the government policy is in the government setup to vaccinate girls.
Yes, ma'am.
It is not banned to, you know,
It is not banned.
vaccinate boys anymore. It is indicated for boys and girls up to the age of 26.
Ma'am, some of the MBBS students are coming to us, boys. When we are teaching them about the HPV vaccination, they are coming to us. Ma'am, just write the HPV vaccination for us also. So, of course, this is not banned, and I think the Sarvavac will get a license to be given from the government setting also to the boys also. It is licensed for boys also.
It is licensed, but whether
Yes,
the
ma'am.
government will give it to boys is a
Yeah,
different
ma'am, because girls are the
It
priority.
is
cervical
already
cancer is the
licensed.
priority. Yes,
It is Gardasil 4 and Gardasil 9 and Sarvavac both are licensed for boys and girls.
Yes, ma'am.
So let us see.
So my case too is a very common case. A 44-year-old lady, P4L4, she is having itching in nose. And one day she herself observed that there is a hypopigmented lesion on vulva. And then she came to us. When we examined, there was no erythema, there was no lesion anywhere else. There was no systemic illness. Next slide, ma'am. So this is the picture what we were able to see. So my question, it is there because we already had 2 lectures. So it's a spot diagnosis. So Dr. Kavita, so what could be the causes of hypopigmented lesion on the vulva? Dr. Kavita Sirohi, are you there?
Anyone who's there, let them answer.
Lichen sclerosis.
Madam.
Yeah, Dr. Kavita. So the spot diagnosis is this thing, lichen sclerosis. But
sclerosis. What is difference between sclerosis and planus?
Sir, it's not planus because planus is mostly erosive sort of thing. It has got plaques on the lateral side, and towards the labia minora, usually it's erythematous, this thing. And what you say, vaginal involvement is there. So there is constriction of the introitus. And this thing, mutilation, can you see the very clear-cut mutilation? You can see the prepuce has been buried into the prepuce. This clitoris has been buried into the prepucial hood. This is a typical picture of lichen sclerosis, not lichen planus. This it is lichen sclerosis atrophicus. So atrophy is the basic feature of it. So, Dr. Shruti, can you tell the other common causes of hypopigmented lesions of the
Yes,
vulva?
ma'am, as there was a confusion. Lichen planus also can very well mimic this similar hypopigmented lesion. But the difference you just told, in addition to the vitiligo, it was already discussed in the previous lecture also how there could be a white lesion, but the other skin changes. Like characteristic feature in lichen sclerosis is the thin papery white, almost like a cigarette paper. That is what they say. With the atrophy of the whole thing, the architecture of the vulva will be totally distorted in lichen sclerosis. So but vitiligo, it will be absolutely normal except for that white lesion. So others could be, as ma'am already is mentioned in the list, chemically induced leukoderma, post-inflammatory hypopigmentation, post-traumatic hypopigmentation, even VIN can also present as white lesion. That's why we usually do further management of these patients or investigate these patients.
So, Dr. Kaji, how will you investigate this case? Because Shruti has told it can be VIN also. We never know. We have just seen a picture. We have not done a vulvoscopy. It may be VIN also.
And it's like this, we must have to go for scopy guided biopsy. Before treating these type of patients, we must have to take scopy guided biopsy. Am I?
Direct biopsy.
We have to do a vulvoscopy and then we have to take a directed biopsy. There could be other lesions also, which could not be visible to the naked eye. So apart from this white lesion, there could be other suspicious areas as well. So vulvoscopy is what. Otherwise, it is mainly a clinical diagnosis, lichen sclerosis. But what we also practice is we do a vulvoscopy in these patients.
because there's 5 to 8% chances of
Chance of-
malignancy.
yes,
This
ma'am.
patient should not be left alone.
Yes.
It is a clinical diagnosis. She should receive treatment because treatment will not only decrease the progression, it will also decrease the chances of this thing, progression to the malignancy.
Yes.
So, can anybody take this question? What can be the features on biopsy which are favoring Alice? I've shown
Yes.
you the slide.
I'll take it.
Although it needs a pathologist to this, but what are the features of lichen sclerosis? Anybody?
There is a thin hyperkeratotic layer. There is thinning of the epithelial layer. We can see there is flattening of the papillae or the rete. The stroma is homogenized. And the most significant feature is there is always an inflammatory infiltrate. So that helps us to differentiate from lichen simplex chronicus. Because if there is an inflammatory dermal infiltrate, it doesn't happen in lichen sclerosis chronicus. So if there are 5 features of this biopsy, then it corroborates to lichen sclerosis.
Yes, ma'am. Very well said. If you only see the biopsy, these are the 5 features. And lichen chronicus also does not give rise to atrophy. So picture will not be like this. There will be more of a screech, each sketch cycle, there will be more of a hypertrophy of that vulva instead of having an atrophy. So, Dr. Venkat, how you are going to manage this case? It's a very common scenario. I think most of us have seen in our OPDs. So when a patient like this come to us, and she must have gone to several doctors before that, somebody must have prescribed some low potency steroids, somebody must have given her antifungal treatment. So how you are going to manage this case, Dr. Venkat?
So corticosteroids may help, madam.
Sir, which type of corticosteroid?
Prevent precaution.
They can be low potency, they can be potent, they can be ultra potent. Which type of steroids?
Low potency corticosteroids.
First, we have super potent.
Topical corticosteroids.
We have to start from super potent to low potent, I think.
Sir, ultra potent is the answer. You have to give her ultra potent. That is the problem. Even I have been a woman is consulting to us who is a very close relative of a gynecologist. She has been to some place. So low potency steroid, most of the people are starting, and which is not the treatment of lichen sclerosis. You have to start ultra potent corticosteroid, which is clobetasol propionate 0.05% or mometasone, which usually we are not starting, or halobetasol propionate. And it makes skin erythematous, more thinning, sometimes ulcer also develop. You have to do a very good counseling of the patient, how it needs to be given. So there is something called FTU, fingertip unit. You have got a finger, so this is your first fingertip unit. So either you can take this much, or sometimes we tell them pea size, or 0.5 gram, 0.5 fingertip unit as application for at least 12 weeks, once nightly. Then when we taper it, then we can go to, because when patient is in maintenance phase, then we can give her less potent steroids. And this tapering is done from 4 weeks to 12 weeks. Even then, the patient should not be lost to follow-up. She has to come back to us. Then maintenance regime, 2 to 3 nightly applications, followed up in 6 months. So sometimes patient do ask, ma'am, kitna lagana hai? So you have to, in a layman term, you can tell them, then in maintenance regime, your 1 tube should last for at least 6 months. So that is how you can tell them. And then every 3 to 6 months, patient has to be told. Shruti, do you think there is some role of self-examination in lichen sclerosis?
Yes, ma'am. That is what we advise when they are put on follow-up. So they require like a long treatment. They have to be counseled about that also, that they should not leave the treatment in between and continue with the maintenance. And while they are on follow-up, they should be examining the vulva with the mirror in front of them to look for any appearance of new lesions, any raised lesions, or if the symptoms reappear, something, then they have to report back to us. So there is definitely a role of self-examination. Otherwise, they have to come to us whenever 3 to 6 monthly we are calling for follow-up.
And there are some cases which we have seen, instead of this, sometimes they develop some thickened lesion, which are very itchy. And patient is very much, distressed with that. So
Yes, ma'am.
patient is having lichen sclerosis all over, but there are some lesions which are bumpy lesions and which are thickened lesions, which are causing very much trouble to the patient. So here there is a role of intralesional corticosteroid. For thickened hypertrophic plaque, we can give her triamcinolone hexacetonide or acetonide. So 1 ml in, that is 10 milligram per ml plus 1 ml of lidocaine, because that is local anesthesia you need to give. 1 ml of prilocaine injection to make it 3.3 mg per ml. Then we have to use a very thin needle because it's vulva, very painful. So 25 to 30 gauze needle once a month for 3 months. Not to inject more than 3 ml in one sitting.
Ma'am, one more thing, it can also be used in resistant cases. People who are not responding to our clobetasol and other steroids, local steroids. This can be injected in those cases also. Like not diffuse, but yes, areas which are not responding.
It is for very small lesions which are
Yes, ma'am. Small lesions, non-responders also they have mentioned it can be used.
Dr. Archana, and the most important thing is we have to break the scratch itch cycle. So we will have to give her antihistaminics and we have to tell her about vaginal hygiene. We cannot
Yes,
do it.
ma'am. Vulval care is very important.
Very nice. And
Here I come in, I ask you, do you permit any of those different cream, lotions that the companies tell? Would you allow any of those vaginal or vulval hygiene agents that everybody is, using these days?
No, ma'am,
plain water.
Water.
Plain water is the best thing.
Advocate soap also. Soap and water. Soap also should not be used. That is what they say for like.
So that is what, I don't know who is listening. We need to be very sure that the cleaning has to be by water only.
Yes.
It has to
Often,
be.
madam, people are using Dettol. They use
Savlon, hot water.
Different thing. So we have to be very
Just
specific.
water.
No Savlon, Dettol, Betadine, nothing. Only simple plain water, and not even hot water. People are very fond of using hot water. So it has to be simple water. And even the undergarments not to be washed in the washing machine. The detergents cause a lot of problem. They are not rinsed properly. So we have to counsel them that please wash it in normal cold water and sun dry. These are basic hygiene things we have for a vulval vaginal problems. These are the basic things we have to consider.
Dr. Sarika has shown us all the atopic dermatitis very well. And they, easy to say, oh, it's just allergy, but the patient who's suffering, it is terrible. So
I would like to,
Yeah, go ahead.
Ma'am, in India, there is a very common practice. I will use this forum because I think everybody knows about it. After every act of micturition or everything, people used to wash it. And the undergarment remains wet all the time. So, and most of the people are just drying it inside instead of drying it in the sunlight. So that place always remains wet. So what you have said very rightly, ma'am, each scratch cycle has to be broken. So if you want to give her something, so it will be food grade, this coconut oil. Yes. Not even that coconut oil, which is having fragrances in that. So if she is very much troubled, then she can use that.
Hurry up, Dr.
Yeah, ma'am. Okay, ma'am.
We have
so I think we have already had this thing.
So I think we need to ask the panelists to pitch in a bit more. So this is a 36-year-old para 2, living 2, presence in OPD, walking with a wide base gait, and she is in agony. She has had severe pain and swelling in the vulva for 3 days. There's been difficulty in walking and sitting for 3 days, and she has fever with chills and rigor for 1 day. She has had recurrent swelling in the same place 3 times before. And every time it just ruptured and pus was drained and it became okay. So this is the appearance. Large swelling, 5 centimeter. I think this is a spot diagnosis for every gynecologist.
Yes, Bartholin's abscess probably because she has fever and pain.
Yes, so it's a Bartholin. Now, what is the treatment? What is the differential diagnosis?
From the location, it is the Bartholin's because otherwise there are a lot of cysts that can appear in the vulva. Most commonly, like the skin duct cyst, that is usually paraurethral. That could be seen. Gartner duct cysts are usually vaginal cysts, usually in the anterior vaginal walls, so they cannot be confused. Others could be like inclusion cysts, fibromas. Sometimes endometriotic cyst can also be there in the vulva. So, and hydradenoma, sebaceous cyst, lipomas, all these can confuse us with Bartholin's.
This is Bartholin, right?
This is Bartholin's, ma'am. The location is for Bartholin's.
So what are you going to do about it?
So since it's an abscess, but she had complained of this is a recurrent Bartholin's abscess. So first of all, I would like to give her analgesics and antibiotics to subside the inflammation and infection that she's having right now. And after that, I can plan two things. Either I can do an IND again because it's a big cyst, or I can plan an excision straight away for her. Because this is like 3rd or 4th time she's coming to us with the...
I will plan an excision straight off for this patient because it's recurrent. So we must go for a definitive treatment. It should be excision.
Yes, ma'am.
So
Excision is...
of course, along with it, we have to
sir?
give the antibiotics.
Dr. Kazi, sir?
Definitely directly go for excision. As it is recurrent with antibiotic coverage, we will go first for excision and we will send a culture.
I will do marsupialization first.
Who said that?
Kavita. Kavita.
Yes. So that is what I had a patient who had a Bartholin cyst which was excised and her wound just broke open and you couldn't even see how bad it was looking. We had to repair it. And he came to me with the information from Google that, you know, my doctor didn't do that Marsu something. He was supposed to have done Marsu. Had a really tough time convincing him not to go to court. So
but he could have gone to court if he had read that recurrent abscesses require excision or even
it wasn't recurrent. It was
I think they have written
the first episode.
She's talking
I'm
of the other
telling you
patient.
about another patient that there's if it's
sorry ma'am.
It's a Bartholin abscess, and if the base is clear, it is non-adherent, then excision is not the treatment.
Ji, ma'am. Yeah.
You would always need to do a marsupialization first. You're going to feel it now once you've taken out the pus. If the wall is clear, you need to take out the wall. You do not need to remove the entire gland. Ruchi, ma'am?
Yes, ma'am.
You differ on that?
Yeah, I slightly differ on that. Because first, yes, you are correct. I am not talking of your patient, but on this particular patient, because
one
of
thing that has happened is that she has never been to a doctor before. It has always had a spontaneous rupture.
Okay. So that is why we expect more of
that
fibrosis.
is why you would, you could do a marsupialization and watch. What's the harm? Because a proper marsupialization has never been done. Hole ho gaya, band ho gaya, fir khul gaya. That is how it's been going on.
But I expect more fibrosis and adhesions because of the recurrence. I wouldn't expect a clear, smooth margin.
So that is, we can actually have a look. So this is IND, culture of pus, antibiotic, biopsy if indicated. And what is your experience about ice packs or sitz bath? Does it work?
Yeah, it helps the patients a lot and it helps in healing also. So once we do marsupialization, when we send them home, we advise sitz bath to them. And they usually follow and no one complained that they had any problem. They come back healed.
So are antibiotics indicated?
If it's an abscess, yes, ma'am, because it's a polymicrobial infection and that has resulted in the abscess being formed. It's a big abscess. She's in pain. So I think,
She's
antibiotic.
having fever with chill and rigors also. So I think she needs.
So she's in acute infective stage only. It is.
Systemic.
I want each of you, don't look at this theory. I'm asking you, which antibiotic would you prefer?
Cefixime.
Dr.
Cefixime or Metrogel.
Cefixime. Dr.
Cefixime with Metrogel.
Okay.
Ma'am, We usually give Augmentin and Metro.
Okay.
Or only Augmentin also sometimes.
Okay. Ruchi ma'am?
Staphylococcal plus Metrogyl. That's Augmentin and Metrogyl.
Okay. Dr.
Anaerobic carbon.
Venkatraman? You're muted, sir. You're muted.
Augmentin and Metrogyl, madam.
Okay. Kazi, sir?
I will prefer Doxy and Metro.
Okay. What do you think of ciprofloxacin? Anyone wants to give that? Because in the WHO STD list, they have Cipro as the first thing.
But E. coli is what they say. E. coli is one of the most common organisms causing this. Otherwise, it's polymicrobial. So yeah, ciproflox can also work.
Yeah, but none of us prefer that as the first line.
Exactly. So we don't give.
So the take home would be again Augmentin or cefixime or doxycycline with Metrogyl. So that goes. And when would you actually biopsy this case? You've done an IND, you've done a marsupialization, but when would you think you want to do a biopsy?
Postmenopausal women where the feel is a little firm, or even in young patients, if you are feeling there might be a solid component.
Okay.
Women more than 40 years also, we should be like a little cautious that why it's occurring, because after 30 usually it regresses and Bartholin's is not that active. That is what like it was written. So after 40 you should be really careful if they come with a Bartholin's cyst. So in that case, even if you're doing marsupialization or whatever procedure, if it's a fluctuant, you can take a biopsy from the cyst wall and send it.
Now I'm asking you out of the hat, how do you decide that it has a solid component or not? Do you want to do a perineal ultrasound with a linear probe?
Yes, we can do that also. Yes.
I'm just giving you an idea that it's sitting there. Now you can always put a linear probe and have a look whether there's a solid component in there with vasculature. And that really gives you a better idea what you're going to find. And then it will help you decide whether you want to go for excision or you want to take a biopsy or you want to do a marsupialization. So it's a mass with solid component, fixed to surrounding tissue, persistent, postmenopausal. So I think we've done with this.
Ma'am, I would like to share one thing. We think that in Bartholin's cyst it's very uncommon to have malignancy. But in 3 years, I have seen 2 cases where malignancy was found when I have taken I have excised and sent it to histopathology. So take home message, it should be this also that if it is a recurrent thing you are doing, so you should always prefer to send a biopsy of that, because malignancy is not that uncommon also in Bartholin's cyst.
Yeah, but if she's a young patient, she's has been
it's
into
little
a
bit unlikely.
relationship and she's got this, then in that case, what are you going to do to prevent recurrence? What are you going to do to prevent recurrence? Has anybody used this word catheter or Jacobi ring catheter?
No, ma'am.
No idea.
We do marsupialization.
No.
Yeah.
We do marsupialization, right?
But the study says that the results are almost same with word catheter and marsupialization.
You should get it, right?
Ma'am, it is not available easily. Even if we have tried it, it's not available
stay
easily.
in place. It should stay in place. Patient gets up and walks and it's gone. So now
the ring is better, ma'am, that way. It doesn't follow.
Next case is for you, and then I'll take the 5th. Dr. Archana.
Yeah, so it's a 38 years old P2L2 housewife. And her only problem is pain. It's not itching, it's pain. She is exactly telling you it's paining, and no vaginal discharge, no menstrual complaint, non-diabetic. She has been from pillar to post, use steroid, candid creams, and whenever somebody examines, it's totally a normal vulva. Ma'am, next slide. So this is a vulva. So ma'am, what will be your provisional diagnosis? It's totally a normal vulva. And what could be the differential diagnosis? That patient is complaining not itching, it's pain. Dr. Ruchi?
Now this is called vulvodynia and can be due to different causes. First is it can be inflammatory, infectious, neoplastic, or even related to some what I say, some foreign body will come over there. But again, vulvodynia, it can be localized, it can be generalized, it can be provoked, it can be unprovoked. And of course, we have dyspareunia, where there is genital pain during penetrative sexual activities. So we could categorize it that way.
So very well said. It is a vulvar pain conditions which the patient is suffering. So Dr. Kazi, how will you investigate this case? The patient has come to you. What you see by naked eyes is a normal vulva. So would you like to investigate this case?
I would like to take proper history and just make it confirm that is it related to some sexual intercourse or it is increasing while at that time or not. So if it is like that, we can go for her to modify the act of sexual intercourse, or we have to ask her for the proper genital hygiene care, or we can provide her some vitamin E oil or for the lubricants or something, or local applicants, or local anesthetic for that.
Yes,
Dr.
Dr.
Archana,
Kazi,
can I
we
add
have done
something?
vulvoscopy in this. Yes, ma'am, please.
First, we have to, after the history, we have to physically examine the patient. If we are seeing any associated lesions, a cutaneous or a mucocutaneous lesion, then obviously our line of treatment becomes that we are going to follow that. We have to find out what this mucocutaneous or cutaneous lesion is. If we are not seeing any lesion, then we have to go ahead with the other diagnosis. So we have to rule out fungal infection, yeast infection commonest. If that is there, we treat her symptomatically. If that is not there, or there is no other lesion, then we take it that it is a case of vulvodynia, and then the general rules that we follow of hygiene, and we have to any topical medication, oral medication, intralesional, all that. So we have to do a physical examination, rule out an obvious lesion that we might be seeing, and we use the cotton swab test for that. So we keep pressing and asking see the tenderness at any point, whether it is there or not. And that's how we go about it.
So Q-tip, so it's a cotton tip which has to be touched at different places. Mostly it is paraurethral or around the vestibule. So there is a Frederick score also. You can just see that whether it is. So our vulvoscopy was normal. The patient was totally normal. So we have to, Dr. Venkat, would you like to give us some insight about the multidisciplinary approach? Who should be included in
You
this?
should be treated by the physiotherapist, madam, sex therapist, and gynecologist. And we have to counsel the patient also properly, give assurance to the patient, and give the common medical treatment. There should be some behavioral modifications, madam. You should maintain the genetic hygiene and care of the vulva also.
Shall we use estrogen or some hormonal therapy in this, ma'am?
It can be in the postmenopausal, sir.
No, sir, this patient is 38 years old.
That's it, madam.
And I would like to add something. We need to go back to the physiology we know. The bone mass index is maximum at 35 years, at 25, and then every year it is going down. When you do a testing, 80% of your women are vitamin D deficient.
Yes.
And a woman who's been in a relationship for so many years, at the age of 38, suddenly she's coming with vulvodynia. I have diagnosed many women with basically vitamin D and B12 deficiency. And once you corrected that deficiency, this problem went away. It took 3 months, but because she was in a relationship before, nothing was happening, and suddenly this has come up. And it had nothing local. Just correcting those deficiencies has made them feel better. So just wanted to share this on this forum, and then we can go ahead, please.
So we have a very good experience when we included our PMR people. So sometimes it is not only the mucosa, it is the constriction of the muscles inside which is causing the pain. So they teach the patient this cat pose, cow pose, and they have to, relax the pelvic muscles. Sometimes it does help a lot. So kindly include the sex therapist also and the PMR for people also along with you. Sometimes it helps a lot. So can somebody tell the first line therapy of a patient who is in very much pain and the even strained relationship because of that, this vulvar pain syndrome? Dr. Ruchi?
Basics is again vulvar hygiene. You have to explain that to her, and any of these coconut oil or vitamin E. But because she's in pain, I think a local anesthetic must be given. That often helps. And you advise them how to give it, not loads of the ointment. Topical estrogen, testosterones, they were at time being propagated, but now because they said the level of serum androgen level, they found it was less in this area. And also, but she is, I think, 38 or 38, I think. So it's the role of testosterone, this is questionable. They didn't see much good effects with it. And of course, if she is not responding to that, we have to give her tricyclic antidepressants and gradually start with low dose and build it up till that pain is relieved. And sometimes even these neuropathic pain agents, anticonvulsants like gabapentin, pregabalin, carbamazepine, also these have to be given, need to be given sometimes. And again, with these also, we start with a low dose and then gradually build up to see at what, and of course they have the maximum limits, but you have to give TCAs and gabapentins like salts to this patient.
And these any role of exercises? Ma'am?
Yes, ma'am.
Any role of exercise? Any panelist, Dr. Kavita, Dr. Venkat, anybody?
Madam, role of pelvic muscle relaxation exercise may be benefited. Pelvic muscle relaxing exercises.
Yes, ma'am. As you just said, ki pelvic floor muscle, like the pelvic floor, the muscle, the unusual contraction of these can actually be the reason for vulvodynia in many of these patients. So yes, pelvic floor muscle exercises, training and retraining. That is what they say. The training of the pelvic floor muscles that can really help these women.
Some pelvic yoga exercises do wonders for these patients, and even acupressure at times. It's really helpful.
So we proceed to the last case, and it's a very, very easy case. It's a 22-year-old unmarried college student. She has history of itching and pain, treated at multiple places for the itching. Now she has ulcers in the vulva, which are very, very painful. And then she has come to you. She has been in this situation recurrent for a couple of months. So currently, this is her finding. This is the look that she has on her vulva. What is this?
Herpes,
Genital herpes. Genital herpes.
Herpes.
So it's genital herpes. So is there any differential diagnosis in this particular case? No.
So it's a spot diagnosis, ma'am.
Yes. So now what is your treatment plan? Anybody? What is going to be your treatment plan?
Once again, it has to be the hygiene part which has to be explained, because it is also associated with other discharge and itching and other reasons. Even if you examine the vagina, you will see other causes.
She is in so much pain that she cannot sit.
Ma'am, we have to immediately start with the antivirals. That has to be started.
Which
Ice
antiviral do you want to give?
We can either give valcyclovir or acyclovir can be given.
Acyclovir.
How much would you give it?
If we are giving acyclovir, it has to be 800 milligram 5 times daily.
Okay. And would you,
valcyclovir could be
think
1
there
gram
is a role of acyclovir ointment over there? Or a plain petroleum jelly?
All that will help is help in slight lubrication so that the friction will be avoided. But local topical acyclovir ointment nowadays they say it is not really advocated in such cases. But ice fermentation works very well for such patient to bring down the pain immediately.
Okay. So she was kept on acyclovir, and then came the question whether her boyfriend has given her the disease, whether he has been unfaithful. So should he also take the treatment?
Yes.
How to prevent recurrence? That is the
And
basic.
one thing is she should be investigated for other sexually transmitted diseases also. Syphilis very important, HIV very important.
Okay.
And
And
both
how
the
are you
partners
going to
rather.
prevent the recurrence?
Counseling plays a very important part in this because we know genital herpes has a very prolonged course and it is a very recurrent disease. So we should not give her any false assurance at the first go. And that itself, the counseling itself, that it is a recurrent problem should make her aware that she has to be very careful with her sexual relationships.
No,
So,
but see, she already has the infection now. Now you are the gynecologist. She's saying that give me anything. I don't want it again. I have classes to go to. Right? She agrees they'll not have any sexual relation. But how is she going to prevent the recurrence?
long-term intake of acyclovir. We don't stop it immediately if she gets relief. We have to continue it.
And
Condoms?
no, she's not going to have sex anymore. How are you going to actually prevent the infection?
Recurrence.
Yeah. How are you going to prevent the recurrence? Her immunity has to be improved. Any viral infection, when your immunity goes down, it recurs. Usually most of the viruses that we have, we don't clear them completely. They are there in our stores. Like even herpes, the one that herpes zoster.
Zoster.
It comes, it stays. Whenever your immunity is down, it hits you again. So you need to counsel her about her lifestyle, about her stress management, about a nutritious diet, and tell her that in spite of all this, you might get a recurrence and then you need to come and we will treat you. But basically, that has to be managed by lifestyle and by raising her immunity. And we need to find out whether there is any cause for her reduced immunity. Because these days, so many youngsters are going through it, but not everybody is getting the infection. So now I ask all of you who are present here, give one take-home message before we really end the session. And one more request, please nominate me from your society. Thank you. And I'll go back, I'll stop sharing and we can discuss our take-home points together. So here.
Can I add one point, Dr. Asha?
Of course, ma'am.
More of sharing. I will not name the company of the sanitary pad, but they have started, because of the dry feel of the sanitary napkin, they have added some chemical on the surface to give a dry feel. But out of every 100 girls, 95 are coming with contact dermatitis. So I have, I always ask my patients what sanitary napkin are you using. So it is always better to use the ones with the cottony feel because any chemical is acting as a irritant. And my take-home message would be we should always examine the vulva very carefully. We should not be ignoring it. And sometimes in a rush, OPD rush, sometimes, patient is complaining, we just give her something for vulvitis and vaginitis, but I think she should always be put on the table, examined, and then prescribed. Because some patients, they're using all kinds of steroidal combinations. They're already used and come. So by the time the histology of the picture of the lesion changes, so you are in a doubt what it is. So without examining blindly, we should not be starting any of these topical agents.
I had a patient who got herpes and she read on Google that applying paracetamol powder makes it heal. And she put that powder to the extent that her whole vulva necrosed. We required 4 plastic surgery sessions to actually cut away all the tissue and put it back together. Means the whole labia majora, minora, everything was. So, Google, my take home message would be that don't trust Google too much. Go to your doctor. Yes. Dr. Shruti, would you like to add something? One point from your side.
You're muted.
You're muted.
Ma'am, I think the itching of vulva, if it is persistent, it should not be ignored. First of all, that and any pigmented lesions also, if they are there in like age group when we know that it could be high risk for VIN or any kind of, they should undergo vulvoscopy and biopsy if possible. So any kind of hyperpigmented, because vulva is something which confuses us a lot. Like we don't know what is normal and what is abnormal. So if we keep on seeing vulvas, like in the sense examining the vulva seriously, then only we'll be able to identify what is abnormal. So that is what my message would be.
Good, sir. One take-home points from you, sir.
Madam, actually, most of the time, as you have told earlier, we'll put the speculum without seeing the vulva. So first to inspect the vulva, even there are no complaints also, so that we can see the normal. Then the patients comes for the abnormal cases, we can diagnose. And most of the cases, actually, it is referred to the dermatologist. So that should not be done. And first we have to take the proper examination, and then diagnosis. Then only we can go for the, if it is not going to treat or if not going to improve, then we can go for the dermatologist and other opinion. That is.
Thank you. Thank you, sir. Dr. Kavita? She isn't responding. Dr. Archana?
Yes, ma'am. I think most of the take-home messages are already given. I am just going to say that vulva is our domain. We can include dermatologists. We can sit with dermatologists. Whenever in doubt, you should not hesitate from the biopsy. Whenever there is something which is persistently causing a problem and you are able to see something as over there, it's preferable to take a biopsy and then remain assured instead of neglecting it and giving her the same treatment again. Because these patients tend to change the doctors very often and the same treatment has been repeated again and again. Kindly take proper history about it. And vulvodynia, I would like to tell you, it's much more common than you expect. People do not come out with this. They are silently suffering with this. And when the patient is telling you vulvodynia and you are seeing normal vulva, you have to understand the patient is really suffering. If you give her antidepressants or if you give her gabapentin, patient totally relieved of the symptoms and her life becomes very easy after that. So this is my take-home message.
Dr. Sujaya?
After so many take-home messages, I think I will just endorse what everyone else has.
Dr. Sarika, you're still here if you can hear us.
Yes, ma'am.
Yeah, one take-home message because you were the opening batsman.
Yeah, ma'am. My message is that first we should, as we now have a clinical classification for vulval lesions, malignant, non-malignant, and even the dermatological lesion, we should first try to make a provisional diagnosis ourselves, and then if it appears to be a dermatological condition, then refer and then recheck ourselves after calling the patient after dermatological examination that whether our diagnosis as per, because now we have categorized the lesions as papule, macule, nodule, red color, white color, it is vesicle, bulle. So first try to make a provisional diagnosis. If it is a dermatological condition, send and then recheck ourselves. That's how we're going to learn.
Yeah. So I think the take-home message from Dr. Sarika is that examine and describe it correctly, and then you will improve and learn. So thank you so much for that. And anybody has anything to say before I give the vote of thanks and end the session? Anybody wants to add anything? No? So thank you very much, Dr. Archana, for helping me with this whole webinar. Thank you, all the faculty, all the guests, and all the delegates for making this program worthwhile. I hope it was as useful to you as it was to me. I also thank Corona Remedies and Mehul in particular for putting things together at a short notice and being our academic partner. Thank you. Thank you so much.
Thank you so much, ma'am, for the opportunity.
Thank you, ma'am.
It's a pleasure, ma'am.
It was great. Listening to you in Raipur has opened my eyes. To all the viewers who are here, in the YouTube, I'm putting a link of a talk on the vulva, which was given 3 years back. So you can have a look at that if you want details. And also you can hear this over again if you want to refresh yourself. Thank you. Thank you so much.
Thank you.
Thank you, ma'am. Mehul, you may